and then I can turn my stuff off, and it's 8 o'clock now, so we can start the webinar whenever you guys are ready.
I think I'm good. Let me just share my slides with the opening so that that's working. Okay.
And then are you also able to click start webinar, or you want me to click it?
Oh no, feel free to start it.
Okay. All right. Are you ready?
Yes.
Yep. Starting now.
Good morning and welcome, or good morning or good afternoon, wherever you are. Welcome to Children's Week 2022 and the first session. I'm Dr. Ruth Adibuya, and I'm the Managing Director for the Stanford Center for Continuing Medical Education. And we are pleased that you are joining us for this first session. Before we get started, just a few housekeeping notes for you. You will be using the Q&A functionality of Zoom to ask your questions of our speakers. And so if you do have any questions, just look at the bottom of your screen and enter your questions in the Q&A portion. This webinar is certified for CME. And there's no action for you right now. You will receive an email from our office 1 business day after this webinar, and you have the option of claiming CME for this webinar. Without any further ado, I'd like to introduce our 2 fantastic speakers that are kicking off our conference. I'll start with Dr. Lisa Chamberlain, who is a professor of pediatrics and the associate chair of policy and community and the Arlene and Pete Harmon faculty scholar at Stanford Children's Hospital. Dr. Chamberlain has focused her career on the elimination of child health disparities. She is committed to do this in 2 ways. First is by transforming the way pediatricians practice by developing and disseminating models of community-engaged pediatrics, by combining principles from both medicine and public health, and 2, by conducting health services research to inform policy. She founded and co-directs the Stanford Pediatric Advocacy Program to train leaders in community pediatrics and advocacy. She co-founded the California Community Pediatric Collaborative, uniting 14 training programs to advance education addressing pediatric health disparities. Dr. Baraka Floyd is a pediatrician at Stanford School of Medicine as well, and the co-medical director of the Peninsula Family Advocacy Program, and she's a clinical assistant professor of pediatrics at Stanford University. She's also the associate chair of diversity, equity, inclusion for the Department of Pediatrics at the School of Medicine. She has spearheaded local initiatives around postpartum, perinatal depression, behavioral health, educational supports, screening for, and holistically addressing social determinants of health and diaper insecurity. Parallel to her local efforts, Dr. Floyd serves as a consulting lead for MLPB, which is formerly the Medical Legal Partnership Boston Unlocking Access Learning Community, both focused on working upstream with patients, families, and care teams to address the social determinants of health. Thank you so very much for joining us this morning, and I will turn it over to Baraka Floyd to lead us in this session.
Thank you so much. I'll get ready to get us started. So today we're with you to talk about innovations to improve pediatric health equity. So our objectives today are to understand how diversity, equity, inclusion, and health equity work together to advance children's health equity, and then to apply diverse methods to improve children's health equity. We first want to take a step back and think about our why. Back in 2020, we were faced with the pandemic of COVID, but also with the extrajudicial killings of George Floyd and Breonna Taylor. This forced us to take a moment and step back and really consider how racism needed to be addressed, both on an interpersonal level and a systemic level. At this point, our Pediatric Advocacy Council and our leadership Education Advancing Diversity program, organized a rally for racial justice on June 4th. And Stanford Medicine's 3 leaders at that point made a commitment to never be silent, to use their influence to promote racial justice, and to affirm that inaction is unacceptable. We recognize that there are many facets of diversity, but we started to address racism first, recognizing that racism is an unpracticed conversation. And starting here would allow us to be able to move forward together. So first, we recognize everything's connected to health. So we want to first think about the historical context of racism. So we can think about things like redlining, the process by which people from minority communities or immigrant communities were shut out from being able to own homes. And so there were certain neighborhoods that were redlined or where people couldn't get loans to own homes. So there was less high quality education. There were less educational opportunities or income opportunities or occupational opportunities, then shutting off opportunities to wealth and social capital. Downstream from that, you see less safe and healthy housing. The built environment doesn't have as much green space. There's not access to transportation or nutritious food. You see food deserts. Then there's not as much affordable healthcare, less social and emotional support. And those systemic barriers all lead to worse health outcomes. And so we think about the social determinants of health, right? That can be grouped into these 5 domains. So we see education access and quality, healthcare access, the neighborhood and built environment, social and community context, and economic stability. All of these are affected by racism. All of these are affected by these historical barriers. So before we start to think about how we define all of these terms, we want to start with a case study. This is a kid that could show up in any of our clinics or any of our hospitals. So this is a 6-year-old with asthma who's had multiple hospital admissions. She's experienced racially charged interactions with the care team, and the family's housing insecure. Fortunately, they're able to stay at a shelter, but they have exposure to tobacco smoke. They also are food insecure or unable to be able to afford enough healthy food for their family. So first, we want to make sure we all understand the same definitional constructs. So we'll take a step back to think about how we define health equity. And as per usual, we're having some tech difficulties. And so we're just going to start our screen share again. And so you can go to pollev.com/BarakaFloyd674, or you can text 22333, or you can snap the QR code here. And so first, we want to think about how we define health equity. So we'll give folks a few moments to respond here. I'll give folks a few more seconds.
Hey, Baraka, I'm looking at the poll. It's Lisa, and it asks how I define diversity.
All right, so
I'm wondering if maybe that's what people are. Let's see.
Maybe that's where we are. Let's go forward.
Zooming ahead.
All right, so I see diversity as multiple races, ethnicity, races, and genders. Other thoughts? So we think about, right, that not only are we thinking about race, we're thinking about gender, we're thinking about culture, experiences. We'll give folks a couple, variety. various topics, SES, ethnicities, ages, races, genders. All right, you guys totally have diversity down. So next, we're going to move to equity. So when we're thinking about equity, it's a little bit different from health equity. Health equity is when we're thinking about every individual being able to have the opportunity to reach their full health potential. So when we're thinking about equity, how might that be different? So when I think about equity, I often think about social determinants of health and some of the barriers that keep people from being able to actually achieve optimal social determinants of health. So when we're thinking about that case and we think about this family, we can think about some of the barriers in these systems where families aren't able to access food or to access housing. Since we're not seeing any responses, I'll give people about 30 more seconds before we move on.
Hey, Dr. Floyd, it's still showing the how do you define diversity?
All right,
well,
so, you know, I think we're gonna call this a tech failure and we'll keep it moving. Okay. So we said health equity is when each individual has a fair opportunity to achieve their full health potential. Everyone jumped in with lots of different opportunities to define diversity. And our Office of Faculty Development and Diversity covers all of those aspects. So really those broad aspects of human differences, really not limited to any aspect. And so for equity, we really think about intentional and unintentional barriers that can get in the way of people getting to their optimal outcomes. So we're really thinking about distributions of resources here, not health outcomes. And so when we're thinking about inclusion, we're thinking about people being able to show up as their full selves, having a true sense of belonging and full access to opportunities. When we think about justice, we often think about criminal justice, but in this context, we're really thinking about a systematic way in which we treat people fairly, allowing people to be able to have equitable opportunities and outcomes in all contexts. And so I'm going to pass it over to Dr. Chamberlain.
Terrific. Thank you so much, Dr. Floyd. When we think of kids, I think it's really important to think about two big groups. One, the children who have serious medical diagnoses, as well as children who are not thriving. So when we think about the kids with serious medical diagnoses, those are the ones that we often treat in our children's hospital who require regionalized care, things with kids with heart conditions, cancer, et cetera. And then for the rest of the population, thankfully, right, those tend to be fairly rare conditions. We have a lot of kids who are well, but not thriving. And the way we see population differences emerging here are things around obesity rates and school struggles. And so when we think about kids' well-being, our two offices really try to address this entire spectrum. Click. If you could advance the animation. And it really represents different kinds of percentages of kids. Kids with serious medical diagnoses, as I said, represent a small percent of our overall population of children, but children who are well but not thriving, it tends to track with economic indicators. So Kids who live in or near poverty represent almost half of the kids in California in the 0 to 5 population. One thing that unites both of these populations that's important to remember and has really emerged as a critical issue around that has come from COVID and our pandemic is the issue of mental health. Mental health struggles have impacted both of these groups, and I would say all children broadly over the last couple of years. Next slide. So we're going to take you on a little quick trip and talk about how we see these population differences emerging. So this is an aerial view. For those of you who are familiar with the Bay Area, this is a shot taken that on the upper right side shows Palo Alto, and on the bottom left shows East Palo Alto. You can see the 101 highway running right through the middle. And IKEA is the little blue building there on the left, and some hotels and whatnot there on the right. You can see University Avenue crossing over 101. And if you followed it all the way up to the upper right corner, you would find us right here at Stanford. So that's a little bit of an orientation. And when people first see this slide, one of the first things they really talk about is, wow, look at all the trees on the Palo Alto side. And I think it's a great illustration that those trees are a result of policy. They're a result of decisions being made, a result of resources, that it's not like the soil is different over there. It's not like the weather is different. The trees thrive on that side of the highway because of resources and political decisions. And it really goes the same for children. So I'm going to walk you through some statistics here. And all of these slides are set up in the same way. First advance. On the top, you're going to see the statistic that represents all of California. On the bottom right will be Palo Alto side, and on the bottom left will be the East Palo Alto side. So free and reduced lunch is a wonderful indicator that lets us know what % of kids live in poverty. You have to live in poverty to qualify for free and reduced lunch in California. And although that is shifting, there's been some new policies around that. But as a result, the school districts track this number very, very carefully. Overall in California, nearly 60% of children qualify for free and reduced lunch. But when we look at how that breaks down, in Palo Alto Unified School District, it's about 10% of kids. And in the Ravenswood City School District in East Palo Alto, it's 90% of kids. So to talk about 60% of kids really obscures the story. You have to break the data down into some finer, more resolved narratives to be able to see what's happening. So that's what it looks like in terms of poverty. Next. It trickles into our health right from the beginning. So overall in California, the preterm birth rate is about 10%. For those living in poverty or less than 100% of the poverty level, it's 11%. And for those who don't live in poverty, about 7%. So again, important to disaggregate that data by income. So you get through your birth and you're growing up, what's the hospitalization rate differences? Overall, in East Palo Alto, we have these numbers actually for these zip codes. 26 per 10,000 kids are admitted in that age range, which is almost 3 times higher than in Palo Alto region where it's 10 to 10,000. These are issues around asthma, trauma, infection, and again, those serious chronic illnesses. So you can see that right from the start and all the way through our healthcare system, these issues really are rooted in where you come from. Next. And obesity, obviously an issue that we've all been dealing with for a long time. Overall in California, when measured at 5th grade, about 37% of our children are obese. So not overweight, but are classified as obese. In the Palo Alto Unified School District, it's about 12%. And in the Ravenswood City School District, it's half. This has its roots, again, like the trees, in how we place grocery stores, food deserts, how we zone for fast food. There's a wide range of policies that we know are at the root of a lot of these population level differences. Next slide. In COVID, everyone has really heard a lot about the disparities that existed with COVID, and I think it has shown a spotlight on many of these inequities. In East Palo Alto, per 10,000 people, 33,341 cases. I don't even want to round it. Every single case is so important. And in Palo Alto, 845. Look at the difference there. That had a lot to do with if you were a frontline worker, how you were exposed, crowded housing, a lot of different conditions. So all of these things combine to create a lot of health disparities and challenges for the kids on the 101 side over the highway there. Next. So we wanted to stop with and think for a minute about your own local community. Think about the segregation that occurs there. Where is your population where we're not living integrated lives? And so we were going to invite you to submit kind of the names of some of the cities where you are. But I think that this is not a unique to Palo Alto or East Palo Alto situation, that we have significant oh, good, it's working. If people want to chime in with their kind of San Jose, East San Jose, or other kinds of regions. We know that this is ubiquitous and is something that a lot of people are struggling with. And a lot of these issues, why don't we go ahead, come into the pediatric office. So we tend to inherit a lot of the failed social policies that result for the kids on one side of the 101 having different issues. Yeah, we can see we've got folks from the Bronx, South Bronx. I know Los Angeles has a lot of different areas. Yep, East LA. It's just getting to that. Oh, interesting. South Coachella. Hello. Palm Springs area. It's fun to see where we all are. Many people would say that segregation is at the root of many of the issues that we're talking about today. And there's a wonderful book by Robert Putnam, if you're interested in these themes. It's called Our Kids. I can highly recommend his writing. He's a sociologist from the University of Chicago, and he talks about how we used to think of all the kids as our kids, and when we had a more integrated situation in communities. And we have, over the last 50 years, really separated into these communities, which you all are articulating here. I'm glad this is working again. Looks like the Central Valley, yeah, there's a lot of segregation there. All right, thank you so much for participating. So I love this quote from one of my colleagues, Dr. Paul Wise: "Pediatricians are the ultimate witnesses for failed social policy." So I know that many of you, day in and day out, when you look at the things that come in over and over again, whether it's food insecurity, housing insecurity, unequal rates of violence, stress, we are inheriting social policies that don't work for everyone. Educational failure is a huge one, right? And I'm gonna talk a little bit about educational opportunities later. Anyway, I think that is why pediatrics has moved so quickly and strongly into this space of working to address child health equity. We know not only our investments will grow with the children into adulthood, and we have that important preventive lens, but also that it just confronts us all the time. And for so many of us, we are, motivated to address that. So with that, I'll hand it back over to Dr. Floyd to tell you a little bit more about what we're working on.
So as we started to think about how we would advance child health equity, we recognized that we needed to understand and help our department members understand the roots of childhood health inequities. And as we started with anti-racism, we recognized that we needed to have a multimodal way to do that. So we designed the HEAL Initiative, and the HEAL Initiative has 4 parts. The first is the HEAL Anti-Racism Seminar. And the goal of that really is to help our department members to be able to have the baseline knowledge of medical racism, structural racism, microaggressions, and effective allyship, to be able to make diversity, equity, and inclusion and promotion of child health equity part of their daily way of being. Recognizing that doing one seminar is not enough, and that all of us come to the table with differing levels of knowledge, the HEAL email challenge was designed as the next step. Health equity rounds allows teams to come to the table and have discussions around real cases, and huddle guides is a way to be able to distill this knowledge down. And so talking about the HEAL Anti-Racism Seminar, we first highlight the fact that race is a social construct, and racism goes beyond personal interactions. And those personal interactions are often the easiest for us to consider, but racism is a system of structuring opportunity and oppression. The system of oppression, solely constructed on how one looks, really is consequences of redlining that have been detailed by my colleague, Dr. Chamberlain, show how the system of racism provides unfair disadvantage to some and advantage to others. And this unfair allocation saps strength of society by wasting resources and is harmful to us all. And so to understand this a bit more, we're going to discuss the different levels of racism. And so racism exists on these 4 levels and is a form of oppression. First is systemic racism. It's often used synonymously with institutional racism, but the key difference here is systemic racism is the overarching system of racial oppression across different institutions or society. So for example, in redlining, it's this discriminatory practices of lending or financial institutions, but it leads to these ripple effects in housing, education, employment, criminal justice, just to name a few. And then institutional racism is discriminatory practices based on socially assigned race in individual institutions. So going back to redlining, you can think about that being an example of institutional racism via financial institutions. Interpersonal racism, we all can probably think of good examples of that from our own individual interactions, and it's expressions of racism between people. And these examples range from implicit and explicit biases, from racist jokes to racial slurs. Internalized racism is race-based beliefs within individuals. And this is really when something like a person of color feels like they're inferior to white folks after growing up in a previously redlined neighborhood with a lack of opportunity and poor education, or a white person feeling that they're superior to people of color after seeing a lack of opportunity and high crime in previously redlined neighborhoods. As we think about anti-racism, we can think about racism as a moving walkway. An anti-racist is an individual who combats racist systems. But first, they have to confront their own biases to stand up to racism perpetrated by others to combat it. For many people, this is really difficult because you have to acknowledge this, and it's challenging and uncomfortable to acknowledge how we as individuals are part of racist systems. So for example, being actively racist is believing white authored papers are superior. Most of us are not actively racist. Believing author, race, or ethnicity is unrelated to the quality of papers is non-racist. So you're just kind of going along with the flow. But actively highlighting papers written by people of color is being anti-racist. This requires work. We have to go against the grain to do this. As we think about how to be anti-racist and how to advance health equity, we have to get to the root causes. And so one of the things that we wanted to be sure of is for our local community to really understand the historical context of how the inequities that we see in our patient population arose. So we thought about East Palo Alto's redlining story as an example of how structural racism can negatively impact a community in multiple ways. So in the mid-1950s to 1960s, the first Black and Asian families moved into the area, and there was protest by white families. 125 white residents protested and actually offered to pay the first Black family to leave. 20% of white homeowners left the area, and by the 1960s, East Palo Alto was majority Black. Once it was majority Black, more systems were implemented that negatively impacted East Palo Alto. Physically, Highway 101 was widened, as you saw in the pictures that Dr. Chamberlain showed. A golf course was developed that further segmented East Palo Alto off, and industrial parks were built that further decreased the availability of green space. You saw how there were lots of trees on one side of 101, and there weren't very many trees on the Palo Alto side. And then with environmental changes, there was a toxic waste management facility placed in East Palo Alto. So that increases the exposure of folks to toxic waste. And then thinking about employment and education, unemployment rates rose, and half of the adults had only a high school education. One of the other things that we think about is ways that we can actually have anti-racist interventions. And a way to do that is to implement programs that respond to community identified needs and decrease the impacts of racism on the community. And so Diapers at the Doctor is an example of this program, this type of program. This program was built based on a needs assessment at Gardner Packard, and it identified cost as a barrier for sufficient diaper supply and a lack of diaper banks. And this impacts the majority Hispanic Latino population. And so we collaborated with Help a Mother Out to bring this program to Gardner Packard families. And it decreases the impact of diaper insecurity on patients of color, but it's guided by patient and community partner expertise, not ours. And so as we're working on our own biases, we have to think about the difference between implicit and explicit bias and address microaggressions. So when we think about this spectrum, this visual is a helpful way for us to think about it. Explicit bias is the iceberg above the water, right? These are the things we can very easily see. Physical violence, hate crime, overt types of discrimination. These are conscious, self-reported, and people are aware of their influence. The iceberg below the water is what's less visible. This is our implicit bias, the attitudes, beliefs, stereotypes, unconscious learning that we have. What tends to sit right along the surface there is microaggressions. Microaggressions are really defined from the perspective of the person experiencing them. And there are these everyday verbal, behavioral, and environmental indignities. They communicate hostile, derogatory, or negative racial, gender, ability, or sexual orientation, or other identity-based things that are insults, whether intentional or unintentional. And so rather than me continuing to talk about it, we're going to watch a brief video that illustrates what they are and how they can land on an individual and the negative impact they can have.
For people who still don't think that microaggressions are a problem,
Oh, you're so well spoken.
just imagine instead of being a stupid comment, a microaggression is a mosquito bite.
Ugh, it's a compliment.
Mosquito bites and their itch are one of nature's most annoying features. But if you're only bitten every once in a while,
No, where are you really from?
Cleveland.
sure, it's annoying, but it's not that big a deal. The problem is that some people get bitten by mosquitoes a lot more than other people. I mean, a lot more. Whether it's on a date,
Oh, your English is so good.
Excuse me?
going grocery shopping,
You know, everything happens for a reason.
I'm just buying apples.
commuting to work,
So when are you gonna have a baby?
watching TV,
We have to keep the Redskins name. It's part of our culture and history.
or just walking down the street with your partner.
I couldn't even tell you were gay.
Mosquitoes seem to pop up everywhere.
Do you know John? Shopping advice. I'm sure too.
Getting bit by mosquitoes every day,
Can I touch your hair?
multiple times a day,
So pretty.
Can I touch it?
hair?
Please? Can I?
is annoying. That makes me want to go ballistic on those mosquitoes, which seems like a huge overreaction to people who only get bit every once in a while.
It's just a mosquito bite. Who cares?
Just another angry black woman.
Of course, beyond just being annoying, some mosquitoes carry truly threatening diseases that can mess up your life for years.
Astrophysics? Maybe you should try this challenging major.
Ow, my dreams.
And other mosquitoes carry strains that can even kill you.
He looked like he was up to trouble, okay? I felt threatened.
So next time you think someone's overreacting, just remember, some people experience mosquito bites all the time.
You're all so exotic. Wow.
And by mosquito bites, we mean microaggressions.
And so as we think about microaggressions, we also have to think about the mental health impacts. So microaggressions can have impacts like depression, anxiety, imposter syndrome. They can even cause people to leave their field. And so it's important as we think about microaggressions to also think about ways that we can support others that have experienced microaggressions. And so you might have heard about a thing called allyship. And so allyship is an action word. It's about what we can do to improve the lives and well-being of marginalized communities that we might not be a part of, or that we might be a part of. There are different ways that we can show up and support as an ally. And sometimes we may need to be beside someone. And so this is really actively listening to help them get a resource or to extend empathy. So if you've seen someone experience a microaggression, this might just be listening to them talk about what their experience was. You may need to be in front of them. So if I have a certain amount of privilege, if I'm, for example, the attending physician on a care team, and my resident has experienced a microaggression, I could stand in front of them because I have more privilege than them, and I can protect them from harm or intervene. Sometimes you might want to stand behind them. And so you're behind that person or community to support them, ready to show up however they might need you to. So you give them the microphone, the platform, and the opportunity. But if they turn around and tell you that they need you to stand up, then you're ready. The other thing that we think about as medical providers is the fact that we all desire to be trusted, but because medical systems and other systems have racism and oppression baked into them, there's a thing called earned medical mistrust. Medical mistrust doesn't mean lack of trust. It simply means that there's differing level of trust, especially when it might impede care. It's an absence of trust that healthcare providers and organizations are able to genuinely provide for patients' interests, are honest, practice confidentiality, or have the competence to produce the best results. It's considered earned because there have been factors often outside of our individual control that have led to patients being let down. So if we think about the case, this mom has brought her child to the hospital multiple times. And so from this mom's perspective, it may seem that the way that we're treating her child is a failure. So she might not trust our care. And so when we think about earned medical mistrust, it's also rooted in all of the levels of racism: systemic, institutional, interpersonal, and internalized. So when we think about historical medical and scientific insults, like things like race-based medicine, it results in decreased trust in medical institutions. Then we think about lack of attention to structural drivers of inequity. So not addressing segregation, not addressing the fact that our built environment in East Palo Alto is very different from the built environment in Palo Alto. That decreases trust in systems and therefore decrease in trust in medical institutions at the institutional level. And decrease in trust in medical institutions then results in decreased trust in individuals within the institution. And sometimes that interpretation of that individual mistrust is seen as a cultural barrier. But when we see it as a cultural barrier, it takes away an opportunity for us to be able to earn that trust back with that patient or family. And so, as we think about an anti-racist approach to clinical care, we first have to learn the legacy of racism in American medicine to avoid perpetuating it. We have to understand that race is a social construct and race-based medicine must be addressed. We also have to recognize that we are individuals acting in a system that is racist. And by admitting that, we're able to become anti-racist. We then have to slow down so that we can pause and heighten racial consciousness so that when there's earned medical mistrust, we can address it. We then have to identify and oppose racism at the individual, institutional, and policy levels. And Dr. Chamberlain will talk with us a little bit more about ways that we work together to do that. And then finally, hospitals and healthcare institutions have to become involved in the human capital and economic development in local communities. So working to understand what communities need and addressing those needs directly with the communities and acknowledging community expertise in that process. So again, then we move to thinking about what are the things that we can do from there. Each person has to chart their own journey. And so we put together the HEAL email challenge by using things that people can read, watch, and reflect on to build their own next steps to becoming more anti-racist. so that they can start to become that way in their daily way of being. Health equity rounds are case-based discussions on the impact of bias on patient care and outcomes. This hasn't been limited to just discussions around racism. Topics discussed have been language access, limited English proficiency, earned medical mistrust around things like mental health conditions, inclusive language, and addressing personal biases, health literacy, technology access, structural barriers, and implicit bias. And in all of these health equity rounds, we start with what the foundational concepts and ground rules are, bring a real case that happened in a unit or a division, and then talk about evidence-based bias mitigation strategies and relevant historical context. Most importantly, the teams think together about ways that they can start hyper-local systems change, either thinking about quality improvement processes or small subtle changes that they can make to start to address the root causes that cause the biases or outcomes that resulted in suboptimal issues in these cases. Recognizing that healthcare is complex and there are many different care teams, we also designed huddle guides so that we would be able to have frontline providers, healthcare leaders, and all members of the care team trained in anti-racism concepts so that DEI could be part of our daily way of being. We utilize our daily management system and standing meetings and clinical and leadership huddles to be able to distill down the major concepts from the HEAL anti-racism seminar. And there are 3 basic themes. So we take these strategies to combat implicit bias using stereotype replacement, which is basically taking a normal or a stereotypic response that you have to something and replacing it with something else, counter stereotypic imaging, contact or starting to be around people who are your out group or folks that you're not usually around, individuating or seeing people as whole humans, and perspective taking or trying to consider what the perspective is in the first person of folks who are not like yourself. Theme 2 is microaggressions and allyship, which we just talked about. And then our last theme is racism and inclusive language, really trying to help de-bias the way that we talk about and document about our patients and families. And so we're going to start from the right to talk about how our unique 2 offices work together. So in our Department of Pediatrics, our Office of Diversity, Equity, Inclusion, and Justice works really to develop, implement, and expand systems to advance diversity, equity, inclusion, and justice. And we diversify our faculty, staff, and trainees, but also really work to build equitable internal systems and educate folks on some baseline competencies so that we have an inclusive culture. We recognize that we are not always perfect, and so we have to build and rebuild trust with restorative justice processes. Again, we recognize that racism is embedded in our systems and that anti-racism must be at our foundation. And by doing these things, we can start to build towards health equity. And I'll pass it over to Dr. Chamberlain to talk about more how we work together.
Thanks so much, Dr. Floyd. I just love listening to all the amazing things going on. It's always so inspiring. Thank you. Yeah, so when we think about health equity over in the Office of Child Health Equity, we then kind of pivot and think about how can we work in our communities? How can we develop and nurture our community partnerships so that there's more capacity in the areas where a lot of our families come from? How can we bridge to policy, to decision makers? How can we bring that evidence that we think will influence child health in a positive way right to the decision makers? And finally, how can we strengthen our research, our equity analytics? How can we bring a community lens to all that we look at there? So I'm going to tell you a little bit more about some of the things we have going on. Next slide. Yeah, so the Office of Child Health Equity was launched last fall. These are some of my colleagues, again, working in these areas, community engagement. Some of our main partners are the Food Bank, which we've been working with for almost 15 years now, the Homeless Shelter Network that exists up and down the peninsula. And for our asthma case, it literally is a group that we've worked with very much because we have had a lot of kids coming into our emergency department and into our hospital who have come directly from the shelter. There is a lot of exposure to secondhand smoke. And in the past, we have helped with renovating some of their spaces, again, bringing the evidence, the mattress covers, the pillowcase covers, changing out carpet to hardwood floors, tiled floors, et cetera, so that there's less asthma exacerbation in those clinics. That was a wonderful partnership that we did. And then working with many of our schools. In the policy engagement realm, we've been working both at the federal and state level, which I'll tell you about, and in research, building out our community-based participatory models, also known as CBPR. Next slide. So the way we see this, our office envisions a world where all children reach their full potential. We strive to create communities and a world where healthcare and life outcomes are equitable and just. And you can hear the kind of public health perspective coming in there, the population perspective, where it also involves life outcomes. Next slide. And so the way that we think about that is partnering with our local and elected officials on women and children's issues, in community engagement, establishing not just partnerships with community organizations, but also primary and subspecialty care groups. And as I said, building in some new data dashboards around outcomes. Undergirding all of this is a strong educational program. We are always looking to train the leaders of the future. All of our residents go through 3 separate required rotations during their 3 years here. They have a month of community engagement where they visit many of our community partners and learn about the equity issues and challenges to equitable health outcomes. They spend a block looking at how do you engage with the media, how do you craft messages and speak with the media and advocate for kids in that way. And then they have a block that focuses on policy engagement. How do you work with elected officials, whether that's at the school district level, the state level, county board of supervisors. There's so many different areas where decision makers are making all these calls all the time, again, that help those trees thrive. And so, thinking about how pediatricians belong in those decision-making spaces and how to raise your voice there, whether that's through testimony, social kind of engagement, social media engagement, or raising your voice that way, et cetera. So we've got some wonderful faculty in Dr. Chris and Dr. Sun who are leading some of those efforts. We are also building out a communication strategy that involves a couple folks, Dr. Alok Patel, who some of you may know from CNN and PBS and NBC and all sorts of places. He's all over. He's a hospitalist with us here at Packard and is building out our communication strategy along with Eunice Dillerman. So all of this taken together, we're hoping to launch these perspectives. In terms of policy engagement, some of the things that we're looking at have to do with transplant equity policy. Dr. Noel Ebel and Dr. Shweta Namyoshi, pictured here, are both pediatric GI doctors and are helping to lead our efforts in terms of bringing our subspecialist voice into policy engagement. Some of the things that, as an example, the GI division is working on are addressing sugar sweetened beverages. How do we think about different policy levers that we have to limit and to create more equity there, increase nutrition and food insecurity protocols for our hospital. Also pictured here is Sherry Sager in the bottom left. She is our Director of Government Relations for our Children's Hospital. Really critical to have these kind of transdisciplinary partnerships if you're going to do this work. We are not experts in this. We as physicians, right, we're super busy and can't necessarily track all the bills. So in partnering with Sherry, and there is a Sherry in almost all of our institutions that can help us to navigate some of these currents and to help us find the time when our voice is ready to and can be most effective. Put up in the upper right there some examples of a tweet that Dr. Ebel sent out and talking about different issues around biliary atresia, making sure that not only does our social media engagement go out in English, but also in Spanish. And they have really built across their entire division a social media presence present. So a lot of the faculty are talking about lots of issues of equity and amplifying each other since they're all on there with different routes and different groups that they reach. And so it's really been impressive actually over the last year how much traction and how much visibility they're bringing to the field of child health equity in pediatric GI medicine. And last, on the bottom right, just wanted to highlight that in addition to having our traditional grand round sessions, we also have policy grand rounds each year. We've had our Representative Anna Eshoo speak, as well as our former Surgeon General Nadine Burke-Harris speak around many of these issues and bringing kind of a state of the child, what is the state of the state for children's health in California and nationally. So that's been fun to elevate these perspectives and help our entire faculty think more about these issues. We also send out action alerts to our entire faculty who have opted in, faculty and staff, so every couple of weeks so they can be updated on issues. And we do have our advocacy council, our residents who lead the way. You saw them leading the way with the March for Social Justice as we kicked off this talk. Next slide. So we are thinking about how the vision is, how can we have this kind of engagement across all of our divisions, across our entire department. You can see here we have many different subspecialists who work in our pediatrics department, and we have started to talk to them and say, how is it different when you have patients who come with Medi-Cal and CCS versus your privately insured patients? And we're really hearing, again, these drivers of inequity. So if you could click it one more time, please, Dr. Floyd. We're hearing how there are real differences in how they're able to take care of their kids. For instance, when we talked to the nephrology department, they talked about how home blood pressure monitoring is really critical. And for their privately insured patients, they're able to get the blood pressure cuffs and the technology they need to be able to get that data at home, but it's not something that's covered on the public side. That's going to drive inequity, right? That's going to challenge the way you can deliver equitable care. Our DB-Peds colleagues are really talking to us about autism treatment being quite inaccessible for our publicly insured patients. Our endocrine department, super frustrated about the new technologies that are coming out are amazing. Continuous glucose monitoring, insulin pumps, et cetera. These technologies work. And if they aren't equitably accessible, we will generate health disparities, right? We're actually going to create more equity issues if we don't have equal access to things that work. So it's absolutely critical that when we see these differences in access, that we don't just go, oh, this is overwhelming, but we're really working to build the tools so that we can understand what's happening, work with Sherry Sager, and bring solutions forward with a physician advocacy voice. So one more click, please. What I wanted to talk about specifically was our adolescent medicine division recently was talking about all of the inequity drivers about trying to serve our adolescent LGBTQ plus population. We were very fortunate just last Friday to have a policy grand rounds with Admiral Rachel Levine. She is the Assistant Secretary of Health and just spoke on Friday. It was such a powerful grand rounds. And so if you would like to watch this grand rounds, there is a QR code that will link to it, as well as a tiny URL there if you prefer that mechanism, that will take you to the grand rounds. It is a grand round, so it's an hour, it's a commitment, but oh wow, so worth it. It was so powerful. And what Dr. Levine spoke to at one point, she talked about how medical discrimination against LGBTQ plus people must end. And she talked about what is happening in many of our states in terms of denying care that has been going on for over 20 years. It's not like this care is new, but we are suddenly denying it and challenging families with child abuse and all these kinds of ideas. And she talks through those and what we can do about it. So really powerful grand rounds I would be happy to direct you to. One more click, please. Some of the things that are happening in California that I want to raise people's awareness about. The AAP, our American Academy of Pediatrics, is supportive of this, is SB 107, gender affirming healthcare. One more click, and you can see what it does is it would prohibit healthcare providers or healthcare service plans from releasing medical information related to the care that we are providing in terms of gender affirming care. So again, there are bills that are being introduced that would protect our patients in California. This is a state bill, so it's just for California, but we are advancing these ideas to make sure that there is equity for all of our families in California. And there's another QR code there that will take you directly to information about this bill, should you be interested. Next slide. Another thing that I think we can all do, and that Dr. Levine spoke about, was how do we make our practices friendly to the LGBTQ plus population. So the AAP has a wonderful guide. You can click into it there again with those resources, as lots of examples of how you can make sure that when a family and an adolescent comes into your space, you are communicating to them that you are a practice that is open and welcoming. Welcoming environments include posting signs like this one. And when I checked it out, when you go to this thing, you can just, this exact sign comes up and there's a whole bunch of different ones, and you can just print them out and you're ready to roll. So they make it very easy, as well as pins you can order, stickers, all these other kinds of things. So it's not like you have to spend your time building such things. So posting signs like this, stickers or pins for your staff and for yourself, having your pronouns on there. That clearly communicates that you value understanding what people's pronouns are. And so that's another thing that you can work on. Next slide. Going further, talking about how do we update our office forms and updates the fields in the EHR. This is an example of how you could do that in terms of gender identity. So again, not having to sit there in a committee meeting and figure out how do we ask these questions. The AAP has done this for us. And so I think this is another great resource. The last thing I'll say is teen confidentiality. So it is important that our teens feel like they can be trusted and heard in a safe space with us in clinic. And this does vary by state. And so this is a link that takes you to the Guttmacher Institute, which is a very well-established institute that helps think about such issues. And if you click through to this, it will take you to a table that lists all 50 states and shows you kind of where we are. So for those of you who are not totally sure exactly how much is confidential and protected by law at this point, I would refer you to that resource. So those are some advocacy opportunities you all can take to advance equity for these families. Next slide. All right, so that's kind of some examples of policy engagement, and that was just last Friday here. So those are the kinds of things that we're really trying to bring forward across all of our subspecialists. Moving now to community engagement, the second arm of our equity office here, we're interested in measurably improving the health and well-being of children and families through community engagement and collective impact models. So less in the policy realm, more in community engagement. We have many community partners, as you can see here, and I'm going to take you through a few examples. Next slide. First, it's important to understand our community partnerships. We have two big realms of community partnerships. On one hand, we have many clinical partners. So we have reached out and built a coalition between the different clinics and that serve our Medi-Cal population. So for those of you locally, it represents Fair Oaks and Mayview. These are clinics that are, Fair Oaks and the Daly City clinics. These are county-based clinics. So San Mateo County runs a series of clinics that take care of Medi-Cal populations. Our clinic is an academic center clinic. And then we have a federally qualified health center, an FQHC, in our community that also does. Now we're parts of different systems, but we all serve the same population. And so about 5 years ago, we joined forces and worked together to advance different initiatives. And I'm going to show you what that looks like. And then we also, as I said, work with different community organizations. And you can see some of the logos here and have been doing so since 2002. Next slide. So this is kind of from the air what it looks like. Stanford there with the S is where we are located with our hospital. You can see the 101 running down the peninsula there. If you go all the way up to the upper left, you land in San Francisco, and down to the bottom right is San Jose. So these are the clinics that I had mentioned. You can see they're kind of geographically distributed. And what's important about this slide, why I wanted to share it, is that the vast majority of babies are born at Stanford. So almost all of the publicly insured deliveries occur in our nursery. So we have full capture of all of the kids on Medi-Cal right from the beginning and their moms, right? And then they fan out to these clinics and we take care of them in these clinics. So we really can, from a population level, if all of these clinics are working together, advance issues for these kids. And I'm going to show you what that looks like for some of us. Next slide. So one of the things that really bothered us was early childhood literacy and struggling with a lot of our families feeling like they weren't kindergarten ready. So I wanted to kind of take us back to our idea here that we started with. The third grade reading proficiency across California is at about 50%. And why third grade reading level is so important. Up until third grade, educators are teaching kids to read. Past third grade, they're reading to learn. Okay, so all of the kids' information in fourth grade and above is going to come in these handouts and things they're going to be expected to read. So if they aren't reading proficiently at third grade, they really start to fall behind. And so the state, not just California, nationally, this third grade reading level is a really important metric. And across the state, only half of our kids are reading proficiently. It's something that is really, to me, troubling. And again, the story is in how you break down the data. In the Ravenswood City School District, it's only 15% are reading proficiently. In the Palo Alto Unified School District, it's 75%. So you can see strong roots of educational inequities there. Next slide. And when you look at the California school personnel, people besides the teachers, so these are like teachers' aides, resource, nurses, reading specialists, etc. The ratio of kids to personnel and students is overall in California, 236 students to one of these personnel. And when you look at it in the school districts in Ravenswood and Palo Alto, in Ravenswood, it's almost 400 students to one of these specialists, and in Palo Alto, it's 137 to one. So I just told you where we need the specialists. We need them in East Palo Alto. But where do we have them? We have them in Palo Alto. This is structural. This is the structural racism we're talking about. These are not accidents. These are how we choose to fund our schools. We are getting exactly what we are designing out of our systems. And so this is something that troubled our group of pediatricians. We were frustrated that so many of our kids at that pre-kindergarten check, that 5-year-old check, we felt like so many of them were just not ready for kindergarten. They felt really like smart, bright kids, and yet they weren't able to write their name. They didn't know some of them, their colors, all of these things. So we've taken on this as one of our issues together. Next slide. And have this idea of creating these clinics that generate kids who are kindergarten ready. So how can we all work together? We have so many touch points 0 to 5. How can we work together to make sure that kids are ready to start kindergarten? So our initiatives break down into parent-directed interventions, building a home learning environment that has a lot of tools and resources, and how do we change the community conversation around early childhood literacy? Much of this is summarized up there in a great resource. So Talk, Read, Sing is one of the programs that we found that we really liked and have embraced. So this is a program started by the Too Small to Fail campaign. You can see some of the materials the kids get. It's kind of like Reach Out and Read. You get materials when you come into clinic. What's different is that we distribute them in the nursery. So right when the kid is born, they get a bundle of materials, and then at 9 months across those clinics that I showed you, and then again at 18 months. So it really complements Reach Out and Read. And in addition to books, they also get CDs so that they can sing together. The families can sing, they get tote bags, they get blankets, onesies, and kind of that visible material is important because as the families that are in the community, they're going to the park, they're going to their place of worship, they're going to Target or Costco, they're carrying these materials around in a tote bag, or the kids wearing the onesie. It's getting that message out there so that families are seeing it in more than one place. Again, not only are they hearing it in their doctor's office, but they're also seeing it with the people that surround them. And this is also the message that First 5 of California is putting forward in all 58 counties. So you see it on bus placards, billboards, etc. So talk, read, and sing to your kids. We also have all of the kind of images. They have really cute little posters and stuff in all of our clinics on the TVs that run in kind of the loops, and then in the exam rooms as well. Next slide. So little libraries, this is another effort that we started. Many of our clinics had this bookcase on the left there that was kind of sad and empty and filled with like free throwaway magazines, that really was unutilized. And what we were able to do is turn it into something that looks like something on the right. We gather gently used children's books in both English and Spanish, and fill these bookcases in all of our clinic waiting rooms, and families can pick up a book and take one. So it's for not just the patient, but the siblings as well, and they can take them home. Again, a way to how we move these resources into the home so that kids have the things that they need to learn. Next slide. Story times. This is something that leveraged being near a university with students that would love opportunities to volunteer. So we have volunteer opportunities for in a couple of our clinics. This had just gotten started when COVID hit. You can imagine all of that got shut down, but we're excited to fire it back up. Having students role model and show how you do dialogic reading, how you can do book sharing regardless of your own literacy levels. And they're in the clinics with the bookshelves and interacting with the families. So we're looking forward to that taking root again. Actually, we've done a lot to get that started. Kind of another way to change the physical space. Here on the left is what the waiting room looked like at one of the clinics, the Mayview Clinic sites. And, it was, didn't say a lot about what we thought about the potential for these kids. It's just kind of a sad waiting room. And yet we know a lot of the private offices locally don't look like that. So we were able to work with local artists and transform it into what you see there on the right. And you can see far right corner, there's their little library that I was talking about. But then there's this beautiful mural that really articulates colors and numbers and planets and English and Spanish and light and animals and all the different letters, etc. You can see the plant did make it over in the transition, but this is really, we think, a much more welcoming space that communicates to families, a lot. It says, we believe in your kids. Next slide. The same thing happened at the Fair Oaks Clinic. So this is one of our county clinics. This is the before picture of the pediatric clinic on the left and the after picture up there on the right. And we wrote about this. What do clinical environments say to our patients? A replicable model for creative advocacy. So really the idea that our spaces speak to our families, and they speak to the potential that we believe that they have. And so anyway, this is it takes some time and some organization, but it's a one-time kind of capital cost. It's not real expensive. It clearly doesn't require ongoing funding. So as a model, we just are excited about continuing to support these kinds of approaches. Next slide. I want to just kind of talk through, in addition to early childhood literacy, which I, just kind of walked you through. Another one is around food insecurity. Another issue that we all kind of decided to take on together. We realized that we were not all screening uniformly for hunger in our clinics. And so we decided that we would do that together, get all of those questions into our EHR, adopted those, and kind of started moving forward. And then during the recession, so the Great Recession, predating the pandemic, we had so many families coming in saying 50, 60, 70% of families saying they just didn't have enough for food. And so at that point, we launched a new program where we came together with a lot of our community partners and did lunch at the library. So what this looked like was feeding children, continuing to provide that school meal over the summer, excuse me, and for not only the kids, but also for parents. That really took hold, and we were able to, distribute tens of thousands of meals. The libraries were part of our coalition, and they said, we would love to get in on this. And so the school meal program over the summer turned into lunch at the libraries. And we were curious as to what do the librarians think about that? Is food in the library a good idea? So we did we led some evaluation efforts around looking at this community-based approach and interviewing librarians and doing a lot of qualitative analysis, and have published this result, which showed that they really were excited about it. They love seeing families come in. And we also interviewed the parents. And one of the quotes that will always stick with me is a mom who said, no, I love taking her because good parents take their kids to the libraries. There's no shame in coming here for food. And so anyway, so our libraries in the summer in East Palo Alto and East Menlo Park are full of food, full of lunches, full of families. And obviously, while they're there, we love it because they're surrounded by books and story times and these sorts of things. So we were able to engage in, like I said, the data collection to understand this model. How does it work for families? How does it work for the people who are working in those libraries? And we invited some elected officials to come and check it out. They did. They were tweeting about it, and it turned into a part of the California state budget for lunch at the library. And this model now has been replicated across the state. So if people are working with library partners at the California State Library website, there's a whole roadmap for how you can become a certified library that serves lunch. What's interesting is, we were doing that, and the state funding is ongoing now to do that. But then we were contacted by Representative McGovern's office. Representative McGovern represents he's a House representative in Massachusetts, Western Massachusetts, and he was looking at innovative models to address child hunger and nutrition. And he was doing a listening tour across the state. Across the country, and came to the Bay Area as well as Los Angeles to learn about innovative models. And here he is on the bottom right, almost a year ago now, came and met with us to learn about how we have addressed these issues locally. Those are all of our community partners. Pediatrics can't do this alone. It really does come from building these community partnerships. And we're in front of one of our clinics, the Ravenswood Family Health Center there. And what is exciting, next slide, is that he, for the first time in 50 years, I'm sorry, the picture didn't show it, will be, there's a picture there of McGovern holding a press conference. And there's going to be a White House summit on children's nutrition and hunger. So the last one was held in 1969, and very excited to get to be a part of that. I also had just added in here, these are the 2 evidence-based questions that are the way that you screen for hunger and food insecurity. So that's just an example of kind of how our community-based intervention, which came from really hearing from our families that there was increasing rates of food insecurity, led to a community engagement with our schools, with our libraries. And then the next thing you know, we were working with policymakers. And part of how we make that transition from community to policy is through the research, through the evidence that we gathered, and we can bring that evidence to the policymakers to disseminate these kinds of models. Last, I'll just say quickly, the third arm that we're working on is that equity analytics arm. Being able to understand what really works is critical. And so thinking about how we can ask and answer questions around equity requires different methods. And one of those methods that we think is very important is community-based research methods. And so we are starting up a new community-based CBPR hub here, led by Dr. Anisha Patel. Very excited to help all of our subspecialists and generalists learn to ask and answer questions in conversation with community. So we can bring that expert voice right at the beginning into our hypotheses and into our data. We're also working with our children's hospital. I'm doing this very closely with Dr. Floyd, I believe later this morning, actually, talking about our children's hospital's equity dashboard. How do we measure the impact that we think is important and that we're having, and where are areas where we still have a lot of work to do? So we believe bringing transparency and data to these processes is really critical. We also are creating a lot of opportunities for our faculty to move their research into direction of equity with seed grants, and beginning to acquire bigger data sets, particularly the Medicaid data sets, so that we can look at some health services research questions around equity that can inform policy. So we've got a great team working on this, and yeah, super excited about it. Next slide. So just Dr. Floyd wanted to bring you back into the conversation here around revisiting our case study.
So we wanted to kind of end with this case study to think about what things would look like once things are realized, so our vision realized. So if this child was admitted to the hospital, she would be admitted and she'd be screened for social determinants of health at admission. The mom might be initially suspicious because of things like earned medical mistrust. So she might ask if they're asking because of her race, but because of things like the HEAL initiative, the care team member that's asking those questions explains that we ask all of our patients this because we know that unmet needs can affect health and we can provide resources that can help. But we understand that folks might have had bad experiences before that make answering these questions uncomfortable. And so we wait for her permission to continue discussing their needs. During the time that they're in the hospital, they get equitable, culturally responsive care while they're in-house. The care team members are able to support each other in these types of interactions. Those who understand mom's point of view and the impact of this encounter are able to bridge the gap for others to bring them up to speed. Pulmonology works really closely with the Office of Child Health Equity to have a partnership with community organizations that can address healthy housing. And subspecialty teams have specific advocacy activities locally, regionally, and nationally to be able to address equitable outcomes for patients. At discharge, based on the conversation with the mom, she decides that she'd like all of the resources that we can give her. So we help her sign up for CalFresh or food stamps on the bedside iPad. We connect her to the food bank, and then we connect her to the family advocacy program to see if there's anything that can be done about the smoke. What's important here is that we're connecting the mom to the really important resources that she needs after her hospitalization, recognizing the importance of continuity from the hospitalization out to the community, because we have these really important partnerships that have been solidified through the Office of Child Health Equity. And then we are able to bolster the ability of our community partners to respond to these community identified needs because we're supporting community collaboratives. And then when we think about our research, our researchers are going out into the community to disseminate findings to community members. And so we built trust in our community. And so all of this comes full circle. And so we hope that through our talk today that you all have been able to think about innovative ways to advance child health equity. So thank you so much for your time. We have our website, tiny URLs up here, and we'll open it up for questions.
Excellent. Thank you both for that fantastic opening session for Children's Week. I was listening to all of the incredible work that has already been done, continuing to be done in this space, and it's just overwhelming. The need is overwhelming, but you can also see the effort that has been done and is still being done in this space. So it was just so great to hear all of that, and then wrapping up with what the ideal scenario, kind of what that case would look like when all of these innovations are realized. So thank you very much for that. We do have some questions in the chat, but perhaps I'll start with just one question of my own, which is, this is difficult and challenging work, and sometimes it's hard to kind of get the buy-in that you need either from your department, from your institution and whatnot. And we're very fortunate at Stanford that we're leaning in with this lens of DEI and justice. So for clinicians that may not be in similar environments where it's challenging to kind of move this forward, what have you encountered resistance to your work, like to expanding the approach to DEI? And if you have, how did you and your team respond? So perhaps I'll start with Dr. Chamberlain first, and then to Dr. Floyd.
Sure. It's a great question. It's interesting. When we first started this work, it was a while ago. And as I started to talk with people in the community, they were not interested at all in working with Stanford. So actually being from Stanford was a negative. We have not been good partners. We continue in many parts of this university to not be good partners. We come into the community, we think we have the answer. We want to come in and do research on the community instead of with the community. And so it took a long time and I should back up and say my practice, I'm a community pediatrician. I see patients. I saw patients in East Palo Alto at Ravenswood Family Health Center for 14 years and have transitioned over to our Gardner Packard clinic, which is a similar kind of FQHC model. We take care of Medi-Cal and uninsured families. So my being out there, my getting to know families, getting to know the schools, continuing to show up, it built that trust. And so there's just no shortcut to that. And so on one hand, Stanford, it's great. We have an amazing chair right now who invests in these. She believes that this is absolutely mission critical. So we have a lot of support from leadership. So I think regardless of where you are, assessing where is your leadership on this, are these issues priorities or not, making a case that they should be, getting that buy-in, and then assessing as a group, what are the biggest topics that you see? Where are the drivers of inequity and how can you address those? Looking for your government relations partners, looking for community engaged partners, looking around the table, who's got a public health degree here? Could they start to partner with some of the people in the community? So I think it's just kind of identifying your issue and then taking some baby steps forward, recognizing that you may or may not be welcome initially, and that's okay. We have to earn trust. Dr. Floyd, other thoughts?
I think the one thing that I would add to that is listening first when you're thinking about doing internal work. And when you're thinking about leadership buy-in, also building a coalition of folks. Because when you think about where resistance might emerge, it's really important to have a diverse coalition of people because we all have blind spots. And I'm now recognizing in saying blind spots, I should say we all have our own biases that we might tend to lean into. So having people around us with different viewpoints is important because then we have the opportunity to be able to get around those points of resistance. I think would be the other thing that I would add. And the other piece is recognizing that we can't boil the ocean. And because this work is hard, recognizing what is the issue that you want to tackle and congratulating yourself for incremental gains. Because we all want this work to be done yesterday, but change is hard and it takes time.
And it's really fun because Dr. Floyd and I get to work together a lot. And it's like, we're both like, we got to fix this right now. And it's like, okay, take a breath. We help remind each other about scope and okay, this is what we're doing right now. We're focusing on this. So yeah, having a wonderful partner to work on this stuff with is critical. But that issue of scope is important. I think you need to take on some things that have quick wins, smaller quick wins, and then have some longer term issues that are going to take longer to address, and that's okay. But I just think tactically it's really important to both have quick wins and longer term initiatives going in parallel.
Yeah. Thank you so much for that. I think I think those responses will really help frame the next steps for our audience. I want to ask a question from Tina, one of our participants. She asked, can you explain a bit more in detail on what options we have as pediatricians to help to reduce smoke exposure in apartment complexes and homes other than education regarding smoking cessation?
So the options often are really limited. And this really is dependent upon your local context. So for example, here in the Bay Area, in different cities, there are different city ordinances that may make it where there's no smoking available in any apartment complex. So for example, in Belmont, you can't smoke in an apartment complex. So there we would be able to really easily write a letter to a landlord to say that there is smoking happening in this complex, it's affecting my patient's asthma. And that would be a way to take action there. But one of the things that's important is in your local context, identifying what the legal resources are that are your trusted curated resources that you can go to. So not everybody has access to a medical legal partnership, but in most communities, you have a legal aid or a legal agency that's free that you would be able to consult with to be able to understand what your rights are in those individual instances.
That's excellent. Thank you. Another question that came in, I think earlier on in your presentation, was around the racial percentage in the school districts that you were talking about. I don't know if you can comment on that briefly to close the loop on that.
Sure. Yeah, East Palo Alto is a now largely immigrant population. As Dr. Floyd had mentioned, it was initially a Black community and then transitioned over to being a largely immigrant community. It is about 75% Latino, about 10% or so Asian Pacific Islander, particularly there's a large Tongan population there. And then the difference is some Asian American and white. Baraka, would you adjust any of that? It's kind of
No,
largely.
it's about, and it's 88% Black, Indigenous, and people of color families.
Yeah, overall, when you add all that up.
Yeah, overall.
About 90%. And I would say when I worked at Ravenswood, I spoke Spanish probably 2/3 of the time. So it is not only Latino, but a recent immigrant community. So, so richly strong and connected. It's a community with a lot of connectivity and a lot of wonderful strengths.
Another question from Vanessa, I think looking for some practical strategies about getting buy-in. She says, how did you reorganize budget, create resources, and establish community partnerships to make this overarching topic a priority? She goes on to say, did it require admin to help resource map? Did you give time for your pediatricians to take workshops, or did you just weave it into an everyday context?
Well, I can say from my side, we started this work in about 2002, and initially all of it was funded through grants and those sorts of things. We really did most of the fundraising ourselves. Our institution did support us a small amount, but the Children's Hospital did. But I would 90% of the budget came from, we raised the money through different kinds of endeavors. Like I said, and I'll hand this over to Baraka, we, in the current environment, have a new leadership, and this has shifted for many reasons that we started with as a high priority. So I think we were really able to hit the ground running in terms of once we are now we have a different kind of support, and we were able to take our work to a new level. And I think it's a great question about how doctors get protected time to take these trainings and things like that, Baraka. So I'll let you speak to that.
Yeah, so I'll speak first to kind of how my individual work started, working on kind of social determinants of health, and then talk a little bit more about our anti-racism trainings. So when I first started doing this work, it was really in the everyday context, recognizing that we didn't have available resources to provide for our families that needed food insecurity resources, housing insecurity resources, et cetera. And once I demonstrated the fact that there were pretty deep needs for our families, from that, I was able to write a grant to get protected time. And so that allowed for me to be able to do even more work and build out an even larger community asset map that we're able to use within our clinic to provide resources. As we thought about how we would roll out our anti-racism trainings, because we had really good leadership buy-in from building our anti-racism coalition that was led by Dr. Chamberlain and one of my colleagues, Dr. Yamane, what we did was built out the HEAL Anti-Racism Seminar. And because we had really good leadership buy-in, we were able to require that 70% of our faculty, staff, and trainees complete that training. I will say that having everyone complete a 4-hour training did require a lot of advertisement, a lot of messaging, but it was doable. But the leadership buy-in was essential and critical for that. And I will say that as we start to move forward, as we do our next year's trainings, we are going to make them shorter, because we recognize that 4 hours is a lot of time, and having that type of protected time for busy clinicians is a challenge.
And I'll just say, as someone who did the training, it was amazing. And it's followed by these email challenges. So it's an ongoing kind of email that helps you revisit the content and think about it some more. So that's, I think we all have a little bit of space to do that. That was a lovely addition to the interventions that Dr. Floyd built.
And the other piece that I think was really critical is we try to tie really deliberately to action-oriented things. So we tie very deliberately to the advocacy action alerts. We tie very deliberately to the work that's done in the Office of Child Health Equity. We tie very deliberately to ways that people can contribute to little libraries and other efforts, so that people are able to actually start to do action rather than just sit and learn in a vacuum.
Exactly. It's really about changing our culture.
That's excellent. I think this is a great place for us to wrap up the conversation. I will end by asking both of you if you have any last thoughts or insights on this important topic for our audience before we close. Dr. Chamberlain, I'll start with you.
Okay. I think when I heard you starting to ask this, I'm just so appreciative. I'm so appreciative that there's such interest in thinking about health equity and addressing some of these core issues. I think that as pediatricians, we have to stand together for our families. The legislation at the state level around the LGBTQ plus issues are just really frightening to me. It's medical discrimination. It's not okay. So I think as these challenges arise, knowing that we have a place to do that there's solidarity, that we can work together to do that with the academy, with each other in our local practices. Anyway, I'm just so appreciative to be asked to speak today, and that so many of you bright and early on a Monday would want to tune in and listen to some of our thoughts. So I think it's just mostly gratitude.
Thank you so much. Dr. Floyd?
I think we are just, it's such a pivotal moment in pediatrics right now. We have such an opportunity to use our position and our privilege and our power as pediatricians to really advocate and move the field forward in a way that advances equity for everyone and does it in a way that doesn't widen gaps. And we really, as Lisa said, have a chance to work with the academy, work in our individual practices, work in our communities to really be able to advance equity and advance inclusion in a way that we hadn't had an opportunity to before. And I'm just so excited, and grateful is not quite the word. It's not a big enough word, but I'm just so grateful to be able to be in this space during this time.
Well, thank you both very much for starting and kicking us off. Such a great start. And thank you to our audience for being here. I want to just call attention that we had a few innovations that were submitted. So please take the time to click on the link and see what other people are doing in this space. And perhaps it will inspire you to do work in your own individual institutions, organizations, or practices. Just logistically, remember that to claim CME, you'll get an email. So there's nothing for you to do right now. And if slides are available, they will be on the activity website. But with that, I want to thank you again for joining us this session. Our next session is later this afternoon at noon, where we'll be talking about urinary incontinence, which a different topic, but and there's a plethora of other topics that are happening this week. So thanks for joining us today. Have a great rest of your day.
Thank you.